go to sleep, correct?
My reading of the interview, to the best of my recollection, is Dr. Murray was not actually totally aware of what his responsibility. When he signed on as his private doctor.
Okay, you're aware that Conrad Murray told the police he was giving Michael Jackson propofol nearly every night for 2 months, correct?
Correct.
Okay. And knowing that that was Conrad Murray's own words to the police, does it make sense to you that Michael Jackson would be seeking only light or minimal sedation where he'd have normal response to verbal stimulation? Does that make sense to you?
I think Mr. Jackson was seeking not necessarily deep sedation. He wanted to achieve a restful sleep state. And that can be achieved with...
In your opinion, is a restful sleep state...
You may finish your answer. And that?
Thank you.
Sure.
I think providing restful sleep does not necessitate conscious or deeper levels of sedation.
Is it your opinion, as an expert in this case, that what was taking place was simply the administration of minimal sedation? Is that your opinion?
Can you be more specific as to the time frame? Because you've referred to a time during which he was administering an infusion for 6 weeks every night, and the more recent care of Mr. Jackson, which was significantly different.
Let's go to... well, again, you're assuming there was not an infusion on June 25th, correct?
I found no evidence that an infusion was being used, correct.
So you're making that assumption?
Yes.
So is it your testimony that on every night prior, or at least in the 2 months prior when Conrad Murray says he was doing a bolus followed by a drip, that in those instances Conrad Murray was doing deeper sedation than what you would call minimal sedation?
Well, first of all, the previous day he apparently received no propofol, and I believe that statement because there was very little residual propofol in the urine sample that was left at, I think, 7 a.m. And the day prior to that, so 2 days prior, Dr. Murray suggests that he gave only half the usual dose of propofol. So certainly for that period leading up to Mr. Jackson's death, there was no evidence that I could find that he received more than minimal sedation with propofol, if that answers your question.
In what date? On what date?
On the 23rd, the 24th, and the 25th.
So previous to that, you believe it was what type of sedation?
During the approximately 6 weeks prior to that, when he was receiving propofol infusions very frequently. I don't know that it was every night because I think he had to have some time off.
Well, Conrad Murray said nearly every night in his statement to the police. So assume he's telling the truth and he gave him propofol nearly every night with a bolus and a drip. What type of sedation would be taking place?
Well, I would say that sounds like he was saying he would give 25 to 50 milligrams by a bolus and then followed by an infusion, which was set up in a 1 liter IV bag where he added the propofol from the...
Earlier you said you didn't know how that was done. I asked you specifically how that would have been done, and you said you didn't know.
Sir, I was asked by the judge not to comment on anything that I learned from speaking with Dr. Murray.
Well, then you just violated the court's instruction.
I apologize. I was trying to answer your question.
The last answer stricken. Disregard it, please.
My question...
The last series of statements. My apology.
Sorry, Your Honor. Dr. White, my question is the level of sedation that took place in those prior weeks. You're coming in here as an expert giving your opinion. I'm asking you, what level of sedation do you think Michael Jackson was being put under all those previous nights?
I would speculate, because I don't know, that it was possibly minimal to moderate sedation. Certainly more than 25 milligrams given over 3 to 5 minutes, yes. By moderate sedation.
What is monitored anesthesia care?
Monitored anesthesia care refers to a situation in which patients are monitored during a surgical or diagnostic procedure.
Or therapeutic, right?
Diagnostic or therapeutic procedure, correct. During which local anesthesia or some other analgesic drugs are typically administered, and the patient is often but not always provided levels of sedation that may vary from minimal sedation to very deep sedation, utilizing drugs such as propofol, midazolam, and other similar sedative compounds.
And as you said, that type of monitored anesthesia care is instituted sometimes in minimal sedation scenarios.
Correct.
You wrote an article entitled, or I think you were a co-author of an article entitled "The Changing Role of Monitored Anesthesia Care in the Ambulatory Setting."
Yes, I wrote that article along with
that
one of my
means-
fellows.
An ambulatory setting means what?
That means outpatient. It can be either in a center apart from a hospital or in a setting within a hospital environment.
You know, I have a quotation taken from the just referenced manuscript. May that be marked Peoples 230 for identification?
It is. It'll be shown to Mr. Flanagan, please.
Dr. White, showing you what's been marked. Peoples 230 for identification. Can you see that from where you're seated, Dr. White?
Yes, I can. Yes, I can.
And you agree that's taken from your manuscript entitled "The Changing Role of Monitored Anesthesia Care in the Ambulatory Setting"?
It looks like it is. I don't recognize it because it's out of the context of the paper, but I'm assuming. Sure.
Just one moment.
I think it was written about a number of years ago. So.
Take a moment, please.
You know, I have a copy of the article entitled "The Changing Role of Monitored Anesthesia Care in the Ambulatory Setting." May this be marked Peoples 231 for identification?
I'm unclear. What's 230 then?
That's a quotation from the article. Dr. White asked to see the actual article.
Well, is it necessary to mark the whole article if you're just focusing on a particular quotation? I think you show it to Dr. White and then we go from there. I'd rather not mark anything more.
Yeah, approach the witness, Your Honor.
Sure. So we have 230, which is a segment.
And Dr. White, it's referencing I believe it's page 1021. I could point you to the area if
Yeah.
you like. Just following therefore.
Can I read the preceding sentence too, since it's a part
Sure.
of one paragraph? It just
Sure.
says the policy of the ASA, which is the American Society of Anesthesiologists, states that the same standard of care should be provided by an anesthesia practitioner during monitored anesthesia care, or MAC, as for general or regional anesthesia. Therefore, and then
And could you continue, please?
therefore, the provisions of MAC should include, as stated up on the
Could you, if you don't mind, could you just
Sure.
read it, please?
I'll be happy to read it. Including a preoperative evaluation. This assumes the patient's undergoing a surgical procedure, obviously. Prescription of an anesthetic care plan, because you're giving anesthesia. The continuous presence of a member of the anesthesia care team, with the proximate presence and immediate availability of an anesthesiologist for the management of emergencies. The standards of monitoring include the usual cardiovascular and respiratory monitoring required for general anesthesia, namely electrocardiogram, blood pressure cuff, pulse oximeter, end-tidal carbon dioxide. In addition to patient monitoring, the anesthesia provider should be ready to administer oxygen, IV sedatives, tranquilizers, opioid and non-opioid analgesics, beta blockers, vasopressors, bronchodilators, antihypertensives, or other pharmacologic therapies so that the desired level of sedation, amnesia, anxiolysis, and analgesia can be achieved without compromising cardiorespiratory function or delaying recovery. Do you want me to read on, or is that?
No, thank you, doctor. And would you agree that traditionally benzodiazepines have actually been the most widely used drugs for sedation during MAC?
Prior to the introduction of propofol and the early studies that I described, that's correct. Yeah.
And would you agree that even drugs such as midazolam, which is a benzodiazepine, right?
Correct.
Even drugs such as midazolam can produce prolonged residual sedation, and the resultant psychomotor impairment can delay recovery.
Yes, when given in large and sufficient doses, the effects and the duration of effects are dependent on the dose and the time frame over which they're administered.
What is meant by psychomotor impairment when reference is made to the effects of midazolam?
Those are fine motor skills, and we use various psychometric tests to quantify the duration of impairment. So they're very sensitive and also involving manual dexterity maneuvers and also cognitive functioning, matching numbers and symbols and various combinations. So they're varying levels of sophistication.
Are the standards for basic monitoring during MAC by anesthesiologists the same as those for general anesthesia?
Yes.
And that would include evaluations of oxygenation, ventilation, circulation, body temperature, and the continuous presence of qualified anesthesia personnel?
I'm not sure about body temperature. I'm not sure that that's routinely and always done, but yes, I generally agree.
You know, I have a quotation from the same manuscript in which Paul White's a co-author. May this be marked People's 231?
It is.
Dr. White's showing you People's 231, and I believe it's on page 1029 of the article.
Okay, I found it.
Okay. And you see that's your article, and it references these include evaluations of oxygenation, ventilation, circulation, and body temperature, and the continuous presence of qualified anesthesia personnel, correct?
Correct, yeah, exactly.
What is, and I may mispronounce it, what is anxiolysis?
Anxiolysis is another term for reduction in anxiety level, or blocking of anxiety.
And based on the defense quadruple G, that would involve minimal sedation, correct? Anxiolysis?
Well, anxiolysis is also part of monitored anesthesia care or conscious to deeper sedation as well.
As well, but it
Yeah.
would also include minimal sedation based on the continuum of sedation?
Correct.
I have another quotation, Your Honor, from the same manuscript. May this be marked Peoples 232 for identification.
Yes.
And Dr. White, I believe this is on page 1032.
Okay.
Now, this is discussing some of the requirements or parameters of MAC, monitored anesthesia care, correct?
Yes, it is.
And it puts in discussing anxiolysis, for example, with just midazolam, even that would fall under the purview of MAC, correct, based on the quotation from your article?
Well, if there's a procedure being conducted and an anesthesiologist is billing for anesthesia services, that is correct, even if no drug is administered and they're simply monitoring the patient during a surgical or diagnostic procedure. That is correct.
So in this situation, MAC level of care, MAC level of monitoring would be in place for a procedure that's pain-free, and anxiolysis is the main consideration, right? Based on your quotation from your article?
As I mentioned, yes, assuming there's a procedure being performed of some nature that would justify having anesthesia services provided.
Where you're saying if just propofol is being provided in the absence of a procedure, then you need less care?
I don't think that's what I said.
Okay. I have another quotation, Your Honor. May this be marked Peoples 233 for identification.
Yes.
And Dr. White, this is actually from, I believe you edited a textbook that Mr. Flanagan had referenced.
I've edited several textbooks.
Textbook of intravenous anesthesia.
Yes, I have. I did edit that textbook, correct.
And showing you Peoples 233. Can you read that out loud and tell me if that's a quotation from your article on propofol?
I don't have the textbook before me, but if you say it's from the textbook, I'll
No, that's okay.
trust.
That's okay. If you want to see it in the textbook.
Well, you're asking me if it's a correct quote, and it's not that I suggest you would do anything other than
May I
quote it
approach the
directly.
witness, Your Honor?
You may.
I'm going to reference you to your own article on propofol on page 119. And you see where I'm pointing here?
Yeah.
Is that the accurate quotation from your article?
It's not completely accurate. Do you see E.g.?
You want to read it straight from the book?
Well, it says monitored anesthesia care is perhaps...
Well, we need you to read it loudly and slowly, please.
I'm sorry.
That's right.
Monitored anesthesia care is perhaps the purest form of IV anesthesia, varying from minimal sedation, for example, patient-controlled sedation, to profound deep sedation, for example, TIVA, which is total intravenous anesthesia.
And then the next sentence.
During these procedures, patients are monitored to ensure their safety and comfort during the operation.
Thank you. You're welcome. So monitored anesthesia care is perhaps the purest form of IV anesthesia, varying from minimal sedation to profound deep sedation. Do you agree with that statement that's in your article?
That's what I suggested in this article, correct.
And that puts forth the proposition that the level of care required by MAC would apply to minimal sedation.
I think
Correct?
you can, during an operation, as I show on this slide. Or you
And I
say-
ask you again then, are you saying lesser care is required if propofol is just being given absent a procedure?
I'm just merely pointing out what this article refers to, and I would like my quotes, if it's possible, to be given in the context,
Okay,
not
but you-
out of the context.
But you're not stating that lesser care is acceptable just because there's not a procedure taking place, correct?
I think the same level of care I try to apply to patients in any venue,
Okay.
whether or not propofol is being administered.
And whether or not a procedure is taking place, it's the use of the drug that's the concern, right? When you're talking about the MAC level of care.
Well, when you're asking me about providing MAC care, that refers specifically to the involvement of an anesthesiologist in a procedure, which may be a diagnostic or a therapeutic procedure. It does not involve other potential off-label uses of a drug. And I just would like to be clear about exactly what's referred to in my articles.
But you're not saying that if it's being used in an off-label manner that the level of care required is lesser, are you?
I'm not commenting on that at all.
Okay. Would you agree that the use of propofol, whether off-label or for a therapeutic reason, would still require the same level of care?
Absolutely.
I have one moment, Your Honor.
You may.
I have another quotation, Your Honor, taken from an article by Paul White, Dr. White, taken from the book Ambulatory Outpatient Anesthesia, Miller's Anesthesia, 6th edition. May this be marked People's next for identification, I believe People's 234.
It is.
Dr. White, did you contribute an article to Miller's Anesthesia entitled Ambulatory Outpatient Anesthesia?
I've contributed several chapters to Dr. Miller's books. As you know, it's a major textbook that's published almost on every 4 years. So I've contributed numerous chapters.
And by the way, Dr. Schaefer's in your textbook as he writes the article, a co-authored article on pharmacokinetics and pharmacodynamics, correct, in this textbook?
Yes, I invited Dr. Schaefer to contribute that chapter.
And he also has written articles for Miller's Anesthesia as well, correct?
I don't know that for a fact, but if you say it's a fact, it's quite possible he wrote an article probably on kinetics again.
Let me show you People's 234. And this references your article in Miller's Anesthesia. Would you like to see the book, Dr. White?
Not if you assure me it's a complete quote. I noticed the last quote you left out some elements, and I just would like to make sure it's an accurate quote, that's all.
And the prior one I left out, patient-controlled anesthesia in the parentheses, and I left out TIVA in the parentheses, right?
Yes.
Did that, in your mind, change the meaning of that quotation? That monitored anesthesia care is the purest form of IV anesthesia, varying from minimal sedation to profound deep sedation. Did that change the meaning of that sentence to you?
That wasn't my point. My point is those were key elements of the statement, and if you're quoting someone, I think you ought to have the courtesy to give the full quote.
May I approach the witness, Your Honor?
You may.
Looking at page 2610, the quotation beginning with the ASA defines.
Mm-hmm. Yeah, right here. Yes.
Okay, you had a chance to review it.
Yeah.
And
I think
in-
it's complete.
In that quotation, you write in your article that MAC level of care applies even if no anesthesia is given at all, correct?
Well, I think what it says is MAC is defined as it's an anesthesia service, so it involves an anesthesia provider. And in some cases, patients who are critically ill just require monitoring by an anesthesia provider, and that's what I'm referring to in that situation, and I think that's what the ASA also is referring to.
Okay. And that
So
would
it
apply
relates to an anesthesia caregiver.
even when no anesthesia is given at all, correct? Potentially.
Correct, yes.
And that the standard of care for patients receiving MAC should be the same as for patients undergoing general or regional anesthesia, right?
As I stated previously, yes.
That vigilant monitoring is required because patients may rapidly progress from a light level of sedation to deep sedation or unconsciousness, and thus may be at risk for airway obstruction, oxygen desaturation, and even aspiration, correct?
Correct.
And based on that quotation, indicating that vigilant monitoring is required because patients may rapidly progress from light sedation to deep sedation, on the defense exhibit quadruple G, that would be going all the way from minimal sedation to deep sedation on that continuum, correct?
Yes, the continuum goes from minimal to what we call moderate or conscious sedation to deep sedation, and then ultimately to, I guess, intravenous anesthesia.
Now, there are also specific guidelines as to the administration of anesthesia in office-based settings, right?
There are, I believe, there's an organization, office-based anesthesia organization, and I'm not, because I don't practice in the office and have not practiced in an office-based setting. Personally, I'm not totally familiar with those guidelines.
Okay, but you wrote about them in your article, though, right?
It's possible, yes.
All right. Well, I'll show you the reference.
Okay.
Your Honor, I have a series of requirements listed 1 through 10 for office-based anesthesia. May that be marked People's 235 for identification?
Yes?
May I approach the witness, Your Honor?
Yes?
Dr. White, I'm showing you page 2617. This is your article on ambulatory outpatient anesthesia.
Yes, it is.
And you see at the bottom of this page, 2617, it lists what you wrote as the guidelines as it relates to office-based anesthesia.
Correct. And when you're providing office-based surgery, as this describes, the requirements are absolutely the same, whether it's in an office, in an ambulatory surgery center, or in a hospital-based unit.
Okay. And these guidelines that you write about are established by the American Society of Anesthesiologists, the American Association of Nurse Anesthetists, and the Joint Commission on Accreditation of Healthcare Organizations, correct?
Yes.
And what is that last organization, the Joint Commission?
I think it's now referred to as the Joint Commission, TJC, and it's an organization that gives accreditation to hospitals, which allows them to bill for procedures and examines the presence of the necessary monitoring equipment and standards for sanitation and other aspects of patient care.
And so, based on these guidelines, if anesthetic agents are used for a procedure in an office-based setting, what are the requirements? If you could please read them.
Okay. They're no different than what I stated earlier, but if you insist, I'll be happy to read them.
Well, he's not insisting. He's just asking you to read.
Okay. Office-based anesthesia, guidelines established by the American Society...
Could you get closer to the microphone? I can't hear you.
Sorry.
Thank you.
Guidelines established by the American Society of Anesthesiologists, ASA, the American Association of Nurse Anesthetists, and the Joint Commission on Accreditation of Healthcare Organizations, JCAHO. Number 1, employment of appropriate trained and credentialed anesthesia personnel. Number 2, availability of properly maintained anesthesia equipment appropriate to the anesthesia care being provided. A complete documentation of the care provided as that required at other surgical sites, which refers to hospital or ambulatory surgery centers. Use of standard monitoring equipment according to the ASA policies and guidelines. Provision of a PACU, which is the post-anesthesia care unit, or an abbreviation for that, or recovery area that is staffed by appropriately trained nursing personnel, and the provision of a specific discharge instructions for the patients. Availability of emergency equipment, for example, airway equipment, cardiac resuscitation equipment. Number 7, establishment of a written plan for emergency transport of patients to a site that provides more comprehensive care should an untoward event or complication occur that requires more extensive monitoring or overnight admission of the patient. Number 8, maintenance and documentation of a quality assurance program. Number 9, establishment of a continuing education program, that is CME, program for physicians and other facility personnel. Number 10, safety standards that cannot be jeopardized for patient convenience or cost savings. Patients must be confident that the office setting adheres to the same standards of care required in a hospital-based or freestanding ambulatory facility.
And Dr. White, would you agree that those requirements and those needs for caution and monitoring would apply equally if propofol was administered in a private bedroom?
I don't. That's a scenario that isn't discussed. It's talking about surgical procedure, a private bedroom.
I'm asking your opinion. Would you agree that those same requirements, those same monitoring requirements, and the same level of care to the patient should apply equally in a scenario where propofol was administered in a bedroom?
Well, I would not administer propofol in a bedroom, as I stated earlier.
Dr. White, would you agree that these same safety requirements, these same monitoring requirements, and the same concern for the safety of the patient should apply equally to a scenario where propofol was administered in a bedroom?
What I could say specifically is when you're referring to performing a surgical or diagnostic procedure, it may be a different scenario than administering propofol for an off-label use.
Is it your testimony that if you're administering propofol for an off-label use, you should use less safety precautions than if you're using it for an appropriate use?
I didn't say that.
Okay,
no.
Then let me ask you again. I'm asking your opinion, Dr. White. Do you feel that these requirements and these concerns for the patient's safety involving monitoring, resuscitation, and all the available equipment, do you believe these should apply equally in a scenario where propofol was administered in a bedroom? Yes or no?
I think that many of the requirements would be appropriate, but I'm not sure all. I don't know why you'd need a well-maintained anesthesia machine, for example.
So you dispute number 2?
I don't know. I mean, I've just been confronted with this now, so you're asking me.
Well, this is your article, Dr.
Well,
White.
of course, but I published many articles, many book chapters. Having a trained nursing personnel and provisions for discharge instructions, I don't think would apply.
Well, let's just go one by one. Do you think if you're administering propofol in a bedroom, in a private residence, that there should be appropriately trained and credentialed anesthesia personnel? Yes or no?
It doesn't set forth parameters of what's trying to be accomplished.
Overruled.
I think there are healthcare providers who are certified to provide conscious sedation that wouldn't be considered anesthesia personnel. So I think that number 1 probably wouldn't apply.
So
Could be a non-anesthesiologist is what I'm saying, if they're properly credentialed.
So based on these guidelines, if you're doing it in an office-based setting, there would be a higher standard of care required than if you're doing it in a bedroom in someone's private residence. Is that what you're saying?
I didn't say a higher. I just said there might be different factors that would come into play.
Well, would those factors...
I didn't say a higher or lower, sorry.
Are you disputing the need for appropriately trained and credentialed anesthesia personnel if you're administering an agent such as propofol in a bedroom? Are you disputing that as a proper requirement?
I'm not disputing it. I'm just saying that this section of my chapter that you're referring to refers to office-based anesthesia.
And I'm referring to a bedroom in a private residence because that's what this case involves. So I'm asking you if you think that same standard of care should apply in a bedroom in a private residence.
Well, I'm pointing out that some of the specifics that are referred to here are not appropriate to the analogy that you're asking me to comment on.
I'm talking about number 1 right now.
If you're asking...
Do you think if you're doing it in an office-based setting, you should have appropriately trained and credentialed anesthesia personnel, but if you do it in a bedroom in a private residence, that's not necessary?
That's not what I said.
Okay, then is number 1 a reasonable requirement for someone administering propofol in a bedroom? Yes or no?
I think if I may, people are non-anesthesiologists are credentialed to give IV or conscious sedation. I think that would be a minimal requirement. So they're not anesthesia personnel. I'm not trying to nitpick words, but I'm just trying to answer your question.
So how would you revise number 1 to apply it to a bedroom standard of care?
Well, I think there are, I guess the analogy would be patients that are on home care or hospice care get sedative medications from physicians, and they're not necessarily anesthesia personnel. Hopefully they're physicians who are trained in the safe administration of these drugs, namely conscious sedation. It'd be a complex rewording to accommodate use of these drugs in a home environment. But it would certainly be worded differently than in this statement, which is an office-based practice environment.
As you look at People's 235, would you at least agree that administering propofol in a home should entail at least the minimum safety requirements involved in administering propofol in an office-based setting?
Yes, I would.
Okay, thank you. This is a good time, Your Honor.
Okay, thank you. Ladies and gentlemen, we are going to take the noon break at this time. Of course, please remember and follow all the written and the verbal admonishments. We'll be in recess until 1:30, and we'll resume at that time. Thank you.